earlier.
Yeah. I had one yesterday, webinar yesterday, and I have one on Wednesday too.
So I think you're on the go.
Okay.
It's 3 minutes. Should we go ahead and start?
Yeah, I'm ready whenever you say.
Yeah. I think we should start. Good afternoon, everybody. Welcome to the second series on the OSCE orientation in psychiatry. We had a lot of participation. I've had a lot of feedback from the students, and there was a need for us to keep this going. We thought we should keep this series going on a weekly basis for the next 4 weeks till the DNV comes out with their exam and we actually know what's happening. Subsequently, based on the need, we can actually do revision programs also on a monthly basis. So today we have a faculty with us, Dr. Naresh Vadlamani, who actually practices psychiatry at Columbus Hospital, Hyderabad. And he's been an active member at IPS National, IPS South Zone. He was a past secretary. He's had noteworthy contributions for academics in international and national journals. And today he's volunteered to help us out with this topic of orientation for OSCE in psychiatry. He's had a rich experience of working abroad, and so he knows exactly what's expected from the examiner's point of view also. So I would request Dr. Naresh to take over this session and take your liberties to choose students if you want them to answer. Anybody who wants to actually answer a volunteer can raise hands. Our technical expert, Mr. Sriram, will assist us, and he'll be able to enable you for actually speaking in person, and so that you will be a subject for examination too. Over to you, Dr. Naresh.
Thank you very much, Dr. Mahesh, and I thank the whole team of Tele Arogya team for selecting me to be a speaker. I don't know if it'll be worth it or not, but I'll try to share my experiences as well as we go along. And right, I'll just try to share my screen. Right. Yeah, I'm Dr. Naresh Vadlamani. I was an ex-associate professor in Bhaskar Medical College. Kindly note down this. As we go along, I'll tell you what happened or why. Right. Actually, I'm a very bad example of a person to give a talk on OSCEs because I took my OSCE somewhere around 2004. So that is 16 years back. And probably now the pattern has changed, the technology has changed. And now, say a couple of days back, when I spoke to one of the DMB students, Dr. Vasundhara, she told me that the OSCEs are 5 minutes. So there are 3 what is called as modules in the exam pattern, 25 OSCE stations of 5 minutes each station, and 4 Viva stations of 5 minutes each again. And then there are 2 clinical component stations, that is 15 minutes each. And I said, what is happening? Like, because that was a shock to me as well. I mean, I don't want to criticize the examiners or the authorities who have mentioned this, but if I was the examiner, I wouldn't ask like this. Like, probably I'll give an OSCE station 15 minutes at least, that is minimum. Right, that's what I faced as well, probably 2004. And now, because of advanced technology and the computerization or whatever, every station probably will have a screen, will post different questions, and then people have to say what is called as look into the screen, read the pattern, and then say whatever is the question asked. So in those 5 minutes, probably either you have to write or you have to talk, and that will be recorded and probably that will be played back. I don't know what that kind of pattern would be at that time in that station. So probably each station will have a different scenarios. And let me tell you that the 25 OSCE stations, the moment you step into the first station, right, it will be like what is called as, I don't know whether you have boarded an elevator, right, or an escalator, either way, right? It's like putting your first step on that escalator, and then it keeps on moving. right? Fast. And then by the time you come out, the whole OSCE stations are over and you don't know what struck you as well, right? So that is the kind of atmosphere probably you'll be entering into, and there's no going back. So that keeps on flowing in one direction till you complete your 25 stations, right? So that is the experience what people have or you'll be undergoing, right? And yes, I mean, previously because of say being subjective or that kind of subjectivity on part of the examiner is taken away, and because it has to be standardized across the country, the exam pattern has to be standardized across the country. So these OSCE stations are designed in such a way so that same questions are asked to everyone, or similar questions or pattern questions are asked to everyone, and everyone needs to answer them in a particular way, in a particular fashion. Right. So that is what is called a standardization across. And that's what OSCE means, objective, structured clinical examination. So that's what it means. Right. So entering into say I'll start giving you some examples, not 25 examples, but probably let us go through the examples and see what they're asking first. So these are the examples which I have taken from the OSCE book of MRC Psych examination. So some of them are literal copies of that same examples, which may not be suitable for our say what is called as exam pattern, but at least that will give us an idea as to what is being asked and what is being expected from the candidates. And then some of the questions which I thought would be more useful to you, which I have thought will fit into that 5 minutes or 15 minutes kind of a scenarios, right? So let me first go through the first question. So as if you are entering the first station, right? Now, this is the OSCE question. So a 21-year-old woman, right? A 21-year-old woman has been referred to your hospital with bouts of depression lasting a few weeks at a time. She takes mirtazapine and has reported no change in her depressive symptoms. You have to see this patient because your predecessor is on leave. So she is a patient known to the hospital. Your predecessor or your colleague was seeing the patient, and then he is on leave. So you have to take charge of that patient now. So now the questions which will be asked on the screen, with the screen which is like this, is take a history of her mood and find out more about her symptoms. Explain to the patient what you think is the problem. Right. So this is the question that literally, I mean, this is a question which I have taken out, very first question from the book of MRC Psych OSCEs. Right. So what is expected from part of the examiner, right, is the candidate will gain marks first for demonstrating the core features of depression, especially the low mood, anergia, and anhedonia, along with additional symptoms that indicate the level of severity. So mainly the questions of severity is, does he have any psychotic features or does he have any suicidal tendencies, right? The candidate should then ask about elevation of the mood in the form of euphoria, irritability, or overactivity. So it means that the patient should ask about ruling out questions or including questions which lead to hypomanic or manic episodes. Now, there should be a question as to the possibility of psychotic features as well, because that's a serious complication of this illness, as well as about suicidal ideation. So that is what an examiner would expect, say, from the candidate, because these are the basic fundamental things which you're supposed to know when a patient with depressive symptoms are being elicited. And the most important to explore is medication history, because you're supposed to now treat that patient who has come with a prescription of mirtazapine. And you need to, what is called as change the medication or necessary or whatever you need to do, but that is what is the decision that you have to make. And it is important to explore the medication history and medical history, any comorbidities in her, or at present what is she suffering from, any other comorbidities it can be there. And briefly look for the presence of comorbidities, in particular anxiety, comorbidities, medical comorbidities, as well as psychiatric comorbidities, that anxiety disorders or even substance abuse. And typically in patients, dual diagnosis, that's what I keep telling people, that it is very important to ask for dual diagnosis questions, right? A candidate may gain marks for delineating a clear history with exploration of potential triggers. So what precipitated this kind of shift, mood shift? Additionally, an exploration for the shifts in mood should be explained, and they should ask about physical health, including thyroid disease, antidepressant induced switching in the past, suboptimal medication regimes, and effects of lithium withdrawal and erratic compliance. Note that at this stage, it is difficult to say definitely what is wrong. So this section should be approached. So these are the questions with caution. The candidate may indicate that it would be useful to obtain information from a close relative. So at this point of time, you always need to tell that I need more information. So you need to indicate to the examiners. Now going on to the next station, the same station, but another part is you decide from the history that the patient could be suffering from bipolar 2 and is a rapid cycler with severe depressive episodes each year and previously unobserved episodes of hypomania. She currently is on a hypomanic episode. The patient says she would be willing to take lithium now that you have explained the illness. Now the question is, prepare to discuss the case with your consultant, including your management plan. So this is what is the question, and it's like basically you're asking everything about the bipolar disorder, right? And then that's what is the management. The management, you need to what is called as, what is the management now? What investigations are you going to ask for the patient to do? And how would you plan your what is called as the treatment? And the treatment, she's already on one antidepressant, and you need to ask whether it's sufficient, or because she's probably having a hypomanic episode now, you want to stop it, or you want to shift it to her to any other mood stabilizer. And she's a young woman. And then you need to plan, you need to tell that what is the immediate management. If she has a hypomanic episode, do you require admission in the hospital? And that decision of admission in the hospital has to be mutual again. I'll discuss with the patient and the relatives whether she requires admission, and is there a risk to her life? Why would you want to admit her? Right? Does it get worse? And then how would you treat her with an antipsychotic? Whether it is olanzapine or risperidone, and you need to choose. Why do you have to choose that medication? And yeah, so medium and long-term management plans. The first thing, acute, is antipsychotic treatment and initiation of a mood stabilizer. And also I would like to consider about mood stabilizer. That's what you need to tell the examiner. And she's of childbearing age, right? So I would want to discuss the implications of this fully with her. And there is a risk of relapse if she is poorly compliant with her medication. I would explore her capacity to make a decision relating to this treatment choice, and in order to, and her adherence, I would provide psychoeducation in the first instance, stressing the need to maintain her medication. I would also refer to for cognitive behavior therapy, which may have a range of benefits in the form of medication adherence, help to identify the triggers, treatment of mood symptoms, in particular depression, and help with stress and lifestyle management. I would want her to be assigned to a key worker, which may be by me or an assistant which someone has in that department. And I think it would be helpful in this case to discuss this lady with multidisciplinary team. This is what we are in the UK, that the system is. And decide if she would benefit from help from a community psychiatric nurse as a part of her care agreement. And I want her characteristic symptoms of depressive or hypomanic episode documented together with early intervention strategies which the patient and the treatment team are to enact when faced with these symptoms. And problem solving, what is now? What do we have to do now? Some candidates are unsure whether to mention the term biopsychosocial in the patient management, and make it clear to the examiner which of the three phases of treatment you are dealing with while addressing this biopsychosocial treatment. So all the immediate midterm and long term. Sorry. So that is about in detail about the questions. So the bipolar disorder, right? So I'll give you another scenario. Sorry, which one? Yeah. Now, this is the second station which you are going to, and this is an example as to what you need to talk to in that scenario. So you are asked to see a patient for second opinion, right? So someone has referred to you, or she has herself has come to you, and she has a long-standing history of low mood and several admissions with suicidal thoughts and plans, and she is currently prescribed amitriptyline. Now take a history of her moods and explore her previous psychiatric history. So this is what is the question on the station, and how do you approach this patient again? Right. So in detail, I'll give you the example. Right. Now, the patient has been depressed for 3 years. She lost her job as she was not performing. Her partner, sorry. Yeah. So she has a partner who is not supportive and who drinks heavily. He has been both verbally and physically abusive in the past. The candidate or the examinee will find that this lady does in fact have atypical depression, namely mood reactivity, variable of mood, tension, overeating, oversleeping, fatigue. Clarify the patient's understanding for the purpose of the meeting, namely given the long duration of her symptoms, to see if there is more that can be done to help her mood. Right. So now what is the task in the station? The task says that you should take a mood history and past psychiatric history. So start with open questions about her mood, and basically all the mood questions, the depressive questions that you have. And then ask about her low mood, poor energy levels, anhedonia, followed by associated symptoms as listed in ICD-10 and DSM-4. Now, what are the problem solving is, what is the question that they asked? So some candidates may fail to identify that this is a case of depression, but atypical depression is most important diagnosis given that it is said to be associated with increased distress, suicidal ideation, and disability compared with typical depression. Despite this, they should be able to highlight the psychosocial stressors that are having an impact on our mood, and differential includes dysthymic disorder and mixed anxiety and depressive disorders. One should make an effort to exclude these possibilities, and owing to limited time, it will be difficult to cover her past psychiatric history comprehensively. It is sufficient to ask about when she first became depressed and the reasons for this. The patient in the station will maintain that she has been depressed constantly since then. The number of times she has been depressed or she has been admitted to the hospital, and whether they were formal or informal admissions, that is voluntary or involuntary admissions. Now, as always, at this stage, whether she has tried to harm herself needs to be clarified. Finally, a medication review. Still considered past psychiatric history would include medications which she has taken for her mood and whether she felt any of them helped. And one would also need to inquire as to how long she took these medications and if she has problems tolerating them. So what it means is that you need to ask about the mood symptoms as well as the past history about her medications, her episodes as well. So that would give a clear picture as to what is going on with her, and that is the answers the question as well. Right. Now going to the fourth question, and this, apart from the OSCE, this can be asked in what is called as the 5-minute viva voce as well. So about the ECT. Right. So how do you describe an ECT? Now, usually the question may be that someone is patient requires ECT, and then you are supposed to explain about the ECT to that patient as well as the father or mother. So you meet a parent, father, who is concerned about his daughter's depressive episode, which is severe and is not responding enough to medications. She is deteriorating. She is admitted in the hospital. After several days of admission, still there is no improvement. You then inform that you believe that ECT should now be considered in view of his or her worsening condition. Both father and daughter have heard only negative things about ECT and want more information. Right. So basic thing is the decision is always the patient's in collaboration with the father or the caregiver. That's what we say. Right. Now, decision is always theirs. You need to give only the information, right? You cannot give your, say, judgment that ECT is better or that is better, or you try to coax them towards one direction or the other direction. So that's how the questioning has to take place, right? Practice in India is completely different, right? So what you need to do is in the examination is go according to the book, right? I'll tell you what a bit later, but always stick to the book in the exam, right? So now you need to talk about in detail about what ECT is and what questions usually they ask about ECTs, right? This is the whole thing brief. I think everyone must have known what are ECTs and the indications and the rationale for ECTs. The procedure you need to explain in simple terms. The treatment length, usually you need to tell the treatment is between 6 to 12 sessions given twice a week, and what are the benefits and what are the side effects, also adverse effects. Short term, what happens? Headache, drowsiness immediately after the ECT, and usually it settles after for a few hours. And then long-term benefits or long-term side effects. So that is memory issues some people can have, not everyone. And how it works. In brief, you need to tell what is the basic mechanism of how ECT works, and the risk of the ECT during anesthesia, what happens, right? And the risk of death during ECT, mainly due to anesthetic reasons, not because of the process itself, the ECG or ECT. There is 1 in 1 lakh treatments, and what investigations they need to undergo before the ECT, right? And then what are the problem solving is what are the ECT? ECT is to be ineffective, inhuman, or degrading. It's not. So that belongs to different error. That is direct ECT. And it concerns also relate to its side effects, and that might permanently damage the brain. That also you need to give the information about, because it doesn't do that. They have concerns and have negative view of the ECT, and this is what is your balanced discussion with them. It has to take place, right? And you should not what is called as downplay the adverse effects or say elevate the indications as well. So you need to be balanced in what you explain to the patient. And finally, the consent form. You need to tell that you are in your full capacity willing to undergo all this, and then the consent ECT consent form is there, and that needs to be filled up as well by them, and consent has to be taken from it. So this what you need to tell in that station, which is the viva voce, when they ask the questions about. And usually in India, I mean, we may ask about, the examiners may ask about what are the medications in anesthesia which they give. Right. So you need to tell them about the propofol, right? You need to tell them about the ondansetron, which is also given, or muscle relaxant succinylcholine, which is given, right? Or glycopyrrolate, which is given to what is called as decrease the secretions, right? So the medications during the process of ECT, and what happens during the ECT and what happens after the ECT, that you need to tell the patients as well, right? So you need to know them. So this is the fourth station, an example of what is being given. And the fifth station, right, it may be a completely surprise. So this is something which is different, right? The question may be something like, you need to say, give interview in a news channel, or you need to write an article in a newspaper about say, some condition, say about depressive illness, about alcohol dependence, and someone dies by suicide. You need to give the interview on suicide, right? So different topics will be there, and you'll need to give it. The main thing is you need to give it in such a way that it is in a simple language, but then it should be structured so that it is easily understandable and palatable to even common laymen, lay public. So yeah, I just gave an example of autism. So those are the typical features of autism, characteristics. You need to give a bit of statistics there. Comorbidities with the autism and etiology. So what is the normal perception or the common perception and what it is not? And how do you screen for them? And any special schools? Do you have any, what is called as in your city or in your locality, any special schools for people with autism? And then those organizations, mobile numbers or contact details, of course, sometimes you may have to give. So what happens is this is the station that will ask you about a simple question on that. Give an interview regarding, say, autism or something like that, or write you an article in the newspaper. So I'm just giving you that there will be surprises in the stations, but then these are all known to you over the past 3 years. You have been reading the books, and probably you'll be very cool about it. And this is about OSCE Station 6. An example, parents bring about their 17-year-old child or son who is having behavioral issues since 10 days. He is more angry and abusive and aggressive. He has learning disabilities. Usually this patient, I mean, in a normal clinic, where I see, the parents bring their son and they tell me that he's already has learning disabilities and he has been assessed in the past by several psychologists. The reports have been given. His IQ is so and so. They also have a disability certificate. He's also on that pension. And now they over the past, in the past also he had some behavioral issues. And usually they tell that he's on medication or something. And then now for the last 10 days, that particular doctor is not there in town or some psychiatrist is not there in town. So they come to you. So that's how I experience in my clinic. Right. So basically, how do the station go? So what it means is do not treat the patient. Don't try to, I mean, you need to tell the examiner there or in the OSCE there that I won't be what is called as over familiar with the patient or try to say, become friends or with the patient like that. But yes, we'll treat the patient with respect, and then the communication has to be what is called as established. To that level, I know the communication will be difficult with a learning disability child, right? So what are the what is called as causes of his aggression or sudden change of mood? So that's what you need to inquire about, right? And they consider the etiology by using biopsychosocial approach and inquire about the following in a way the patient can understand related to disability itself. The mom is worried about you, sorry, specific conditions are known to have association with behavioral disturbance, that is niche mayhem, phenylketonuria, etc., and psychiatric comorbidities. You need to ask about depressive illness, bipolar disorder or psychosis in that patient, and organic disorder like epilepsy. Is it an epilepsy or hypothyroidism or UTI or any other fevers can bring about this change in behavior? Physical conditions like constipation or esophagitis, dental caries, or worsening of sensory impairment, and medication, easy on any medication that may cause paradoxical agitation, and substance abuse, is it there? And look for evidence of any emotional stress in the last 10 days or 15 days. Has there been any event that took place and then that's why he's feeling a bit stressful? Ask about familial relationships and recent stressors. Are there any arguments at home or school? Consider any behavioral component to the self-harm and any positive gain. And this should not be assumed to be attention-seeking behavior, but rather a way of communicating distress or unpleasant feelings. More appropriate ways of communicating is something that a psychologist or psychiatrist could assist with. Now you ask about the social events or the social relationships that he has around. Inquire about close relationships. Has anyone close to the family or a friend or a member from the school moved away? Has the daily routine changed? Have they recently moved home or something changed at home? Right. And then what is the situation? Why is he angry or aggressive now? So this is a challenging station as you will be attempting to take history in a short time from someone who might not be forthcoming or who will be disturbed. To help with communication, you should use simply phrased questions and concepts, use clear and direct language, keep reassuring the patient throughout. Do not appear hurried or intimidating. Allow time for answers. Do not worry about the silence. Avoid jargon and use age-appropriate style and terminology. Use body language, gesturing, and alongside speech if necessary, and repeat questions if necessary. So I'll do one thing. Yeah. So I will stop here a bit and I'll ask if there are any questions. I don't know how to expand this.
Sir, you wanted to come out of this?
No, not come out.
Huh.
I want to what is called as not come out of it, but I want to see if there are any questions and if they have any doubts, whether they can ask so far.
Okay. We're just waiting, sir. No questions have been keyed in yet.
Right. How do we get to the whole what is called as?
When you look at the bottom, you will be able to see the Q&As.
Okay, it's on the top actually. Okay. Yeah, I'll try to.
There's one question which has come in, sir.
Right. Right. Okay. So will time be sufficient? Are you able to hear me?
They will not be able to respond, sir.
Yeah, no, that's okay. I'll respond to the question.
Yes.
Yeah. So will time be sufficient to answer comprehensively? No, time will never be sufficient. Right. You have to what is called as balance. What are the important points that you need to elicit, or what is focus on the job which is there, and then prioritize among the various questions. Now, suppose you have depressive symptoms. Say, for example, I'm just giving an example, not that you have to cut short on this, but suppose you have depressive symptoms and you need to elicit the depressive symptoms. And there are around 9 questions to fulfill the criteria. But I mean, you can ask 6 questions or 7 questions, and by the time will be over. But the main thing is, have you asked the most important prioritizing questions or not? Right. The first 3, say what is called as main symptoms about anhedonia, about anergia, about low mood, right? And then the serious questions, so about suicidal thought, right, or any psychosis. So these are the 5 questions which have to be asked, and the other questions you can ask. And by the time will be cut off. So suppose I'm giving you an example like that, right? So that's what you need to do. I mean, I know it's difficult to prioritize at that time, but then you by practice, see, all this you have to keep practicing. Take examples. Take examples of OSCE stations, and then practice it with your colleague, practice it with your mother, father, relative, brother, anyone who is at home, because you want to talk. That's all. In those 5 minutes, what can be talked in the stations, and then practice it with someone, your senior, or you can ask anyone else as well. So keep on practicing those 5 minutes with a timer. So only practice can what is called as help you get through the stations, right? And OSCEs can you guide what areas need to be focused, like EEG, neuroimaging, child psychiatry, right? Now the thing is that 25 stations plus 4 vivavos, so that is 29, plus 2 clinical scenarios, which is 31, right? So it means that every corner of the book will be asked. Right. So prioritizing means you have liaison psychiatry, you have different specialties. So in every specialty, a single or other questions will be asked, and psychiatry is so vast. Say forensic psychiatry questions can be asked, child psychiatry questions can be asked, geriatric psychiatry questions can be asked, liaison psychiatry questions can be asked, right? Community psychiatry questions can be asked. So all types of specialties which psychiatry has, so their questions and the stations can be asked from them. So you need to be prepared for all that, right? Can leading questions be asked? Right. Now, let me tell you that these are stations. So I don't know what is the response from the computer. So stations have probably computers there, and then a question will be displayed on the computer screen, and then you may have to type or answer whatever is the required as per the requirement. So that has to be done. So at that time, there's no leading questions anywhere. So you won't get probably a reply. I don't know whether you get a reply or not. So whether you're asking the right questions, that is more important. That will be probably recorded. Right. Yeah, so that's a very good question. Since DNB has ruled out real patients, what will be the language of communication with, say, dummy patients or on the computer? Local language or English? So my guess would be English only, right? Because it's conducted across the country in different area, in different centers simultaneously, probably. So the answers will only be in English. You may have to ask only in English. So not local languages will not be there on the computer, right? I think those are the questions as of now. So let me continue my presentation because these are the things. See, I'm giving you examples with answers, right? Because I'm not what is called as putting you in an exam situation and trying to elicit questions from you or elicit what is called as examination pattern of practice from you. The reason is that you already know the subject. For the last 3 years, you have been reading, the subject is known to you. These questions I'm trying to, display so that you will get an idea as to what is expected from you, right? So that is the reason why I'm giving you the answers as well, what is expected from you. So in the next station, and delirium is definitely a question that will ask that will be asked either in Vivavos or in one of the stations, right? And it is most important referral, say either symptom or diagnosis by the liaison psychiatry people or in the Department of Medicine or in MICU or ICCU. You are the person whom they call even in the middle of the night and say that this person is talking irrelevantly, he's jumping out of the bed, he's uncontrollable, right? And then we are not able to manage him. We have given him sedation of 0.25 Restil tablet and he's not sleeping, or we have given him IV or IM lorazepam, he's not sleeping. Right.
Naresh, just a minute. Can you go on full screen mode?
Yeah, sure. Sorry. Right. Right. Now, talking about delirium, I think every one of you know about delirium. And in those 5 minutes, probably you need to take a brief history and mental status examination of the patient. If the patient, that's what in the scenario says that the patient is conscious, right? I mean, delirium is fluctuating consciousness. So that's what you need to know, that he's not like completely unconscious, or what is called as, it is acute confusional state, but then there are intervals between. So if the patient is able to talk, then you need to talk to the patient to clarify with the patient why he's not eating or drinking or during that time, or does he have any abnormal delusions or beliefs. So is there a current or previous history of alcohol or substance abuse, mental status examination, brief cognitive assessment, and is the patient oriented and lucid. So that's what you need to do, the mental status examination, right? At that time in the ICCU, the relatives may be there, may not be there. So, but it's ideal if you talk to the relatives as well and get as much information as possible. So that's what you need to state there as well. And brief history from the doctor who has referred to you. The ICCU, there is a doctor and doctor has seen the patient deteriorating and in confusion. So you need to ask the doctor, what is the history? So how long has he been an inpatient and when did the team first notice the problems? Did the change in mental state come on abruptly or gradually? And has there been an associated history of fluctuating lucidity, disorientation, changes into consciousness and attention? And is there any associated history of visual hallucinations? So any obvious changes to the patient's sleep-wake cycle or emotional disturbances? Is there a previous history of psychiatric problems or memory problems? Previous history of delirium when he was admitted in the past, and what is the state of his current physical health, and are there any comorbidities? That's what you need to ask for. And has there been prescribed any new medications which can trigger his delirium as well? Has his family expressed any concerns around premorbid memory and functioning? And what is the team's future medical plan? So you're asking the doctor, what is the plan? I mean, what are you going to do with this patient? And any relevant investigations which they have sent, right? And you need to summarize and give a differential diagnosis to the doctor. So that's what it means. So at this moment, I'm thinking that he could be suffering from most common thing which we find is the medications, whatever are the medications they have juggled in the past, and those medications leading to delirium. And the second most commonest cause is the UTI, especially in the elderly, right? Yeah, in the young patients, you need to rule out any drug abuse, alcohol withdrawal, delirium as well. So that's what they'll refer the patients to you for. So that's what you need to tell about the differential diagnosis, the main differential diagnosis, and any additional points. So I mean, basically delirium, what is the difference? I mean, delirium is defined as etiologically non-specific syndrome characterized by concurrent disturbances in consciousness. And so primary thing is it is a disturbance in the consciousness And then all other mental status examination parameters are disturbed as well. There is no previous psychiatric history of note, and the problems, if there are no previous psychiatric history of note and the problems are relatively recent and rapid onset, right? Then the delirium or acute confusional state should be considered according to ICD-10 criteria for diagnosis of delirium. Symptoms in each of the areas should be present: impairment of consciousness and attention, global disturbance of cognition with perceptual disturbances, which usually tend to be visual hallucinations, and psychomotor disturbances, emotional disturbances, and other potential differential diagnoses could be considered, including mood disorder or acute psychotic disorder or pre-existing dementia, delirium superimposed on dementia. Potential causes of acute confusional state in this case might include infection like urinary tract infection or medications of polypharmacy, steroids, or antibiotics. Now, risk factors for delirium include old age, medical and psychiatric comorbidities, underlying cognitive impairment, psychoactive drug abuse, polypharmacy, males, and risk factor for delirium can be characterized by predisposing versus precipitating factors. Now, the next station, right? So, in viva voce, movement disorders, these are also, I think, they will be asked in one of the 25 stations or in viva voce station. Then movement disorders are compulsory, again, the most important part of any management of any in psychiatric illness, right? Now, usual complaint, and when you give, usually the example which they give is this patient, say, for example, is a 45-year-old male patient. He's suffering from 25 years of schizophrenia, paranoid schizophrenia, and there were episodes where he was admitted in the hospital. He has been on every antipsychotic. He has seen every psychiatrist in the city, right? And then, say, in the last 10 days or 15 days, they have been to another psychiatrist, and I mean, he has some movement disorders, or he may be stiff, right? Or he may have slow movements. And then the parents or the relatives, whoever they are there at that time, when he's a 45-year-old or she's a 45-year-old lady, they bring to you that he's having movement disorder, right? So the first thing that you need to think about, all the movement disorders in psychiatry, but NMS, right? And the risk factors for NMS and why you are thinking about NMS as well. Extrapyramidal symptoms, classify them: acute dystonias, akathisias, Parkinsonism, and tardive dyskinesia. And also you're thinking that movement disorder can be because of positive and negative schizophrenia as well, the behavioral changes that can occur. Catatonic schizophrenia is extremely rare. Probably I have seen my last case, probably around 10 years back. That's it. After that, I haven't seen a patient with catatonic schizophrenia. And any other neurological movement disorders that you are suspecting, that's what you need to tell about the differential diagnosis. And how you are going to say rule out everyone by history, examination, investigations, management, how we are going to do that, right? Short term and long term as well. And the clinical component, that is 15 minutes. There'll be 2 stations, and probably it will be like a long case. I mean, when we did our MD examination, there was a long case and 2 short cases. And long case typically was dual diagnosis. The patient was having schizophrenia or with cannabis, or he's having bipolar disorder with alcohol dependence, right? So that was compulsory cases. And if you don't, because only when they have such a long case to discuss about, and usually the patient is suffering from them for the last 10 years or 15 years, treatment resistance can be discussed as well in them. Treatment resistant schizophrenia, treatment resistant to bipolar disorder, and comorbidities, everything in, I mean, CTP can be discussed when you are given these 2 cases, right? So these are the common cases which you need to know. You can't skip them. And then, yes, very favorite of every examiner, right, is cranial nerve examination. And you need to ask the appropriate questions for every cranial nerve that you examine, starting from the first cranial nerve, olfactory nerve, and going back to the 12th cranial nerve as well. So all the questions that you need to ask, you need to know. And this is also very favorite of the examiners as well as in the OSCEs. One station will be there in the OSCEs or in clinical exam, or in what is the clinical examination part, as well as the viva voce part as well. Now, what are the examiners assessing, or what is the OSCE assessing you? So at that point, usually when is that whether you're professional or not, whether your your demeanor is good or not, empathetic, knowledgeable, practical, and a safe doctor or not. So that's what the examiners, from their point of view, they want you to, what is called as, have these kind of characteristics. When you approach them, the patient, with questions, what are the questions that you tend to ask or you tend to write, right? And how you should approach in a clinic when we are sitting. I mean, forget about the OSCE part or forget about the examination, everything else. You are sitting in a hospital, you are sitting in your own clinic, there's a patient coming to you, a new patient, first time he's coming to you, right? How do you view that patient? That the best way possible is, yes, he's my close relative, he's my brother, she's my sister, right? He's my aunt, my uncle, or my very close person. And typically, you need to think that their complaint is hidden. They may tell you that they have stomach pain, they may tell you that they have knee pain, right? But you need to think that they are complaining of severe chest pain leading to MI. So that's what you need to think. So what it means is that whatever complaint they gave, you need to ask for serious complaints. First, rule out what is called as the life risking questions. And in our specialty, they may not tell you the right question, or they may not tell you the right complaints. They may tell you that common symptom they tell you is a headache, and the patient may be suffering from recurrent depressive disorder. So you need to elicit from them, right? And you need to think that I need to treat my relative, though his complaint is something I have elicited. These are the complaints, and this is the diagnosis, and I have to manage him in the most safest way possible. Right? You need to think in those terms, and I have to manage him in such a way that he or she becomes functional in the shortest possible time. Right? So whenever you are approaching any station, or whenever you are approaching even practically in your clinic, you need to think in these terms. Once you think in these terms, automatically all your subject falls into the different important criteria, categories. Right. So this is very important, how you should approach a station or how you should approach a patient. And when you're thinking in these terms, automatically you'll be asking the prioritizing questions, because now you say your brother is sitting in the clinic, say for example, right, and he's complaining of chest pain, he's complaining of knee pain, or he's complaining of headache. You have 5 minutes to save his life and to decide, say, to make him or manage him, tell him about the management plan for the next 3 months so that he becomes functional. So you have 5 minutes in that. So what do you are going to ask your brother? So that's what it means. Finally, you need to behave, act, demonstrate in these OSCE stations and have the knowledge about psychiatry as if you have an experience of 20 years, right? And in private practice, where every word is a legal statement, every deed or every prescription you write or every word you say is life-threatening, or what it means is life-saving, either way. And every rupee spent by the patient has to be justified. Understood? You say that you ask the patient to go to that kind of investigation and get that investigation report. So you need to justify that investigation. You're supposed to be a super consultant, and that's what you need to demonstrate at the OSCEs. Right? I know this is very difficult to conceive, but that's exactly what they are expecting of you when you enter the OSCEs. Right? Now, I told you in the past, the very introduction, that I was an ex-associate professor in a medical college. And now I'm a private consultant completely. And I know what I'm going through with every patient every single day. Right? And all these three statements, that every word that I speak has to be in a legal way. It has to be legally right. And every deed, right? I have to think that nothing should happen to the patient. right? And every rupee that the patient spends for any investigation or any tablet, that has to be justified. Why I'm giving this, right? So thank you very much. And yes, I'm sure there'll be a lot of questions and I'm ready to answer those questions. So shall I take the questions? Are you able to hear me? Hello?
Yes, sir. Yes, sir.
Right, okay.
Naresh, we can
Yes.
hear you.
Hello? So shall I close the screen or what should I do?
You're able to
Naresh,
see the
you can
question,
stop.
sir?
Yeah, I can see the questions.
You can close the screen
Okay.
and you can look at the Q&A and pick up the questions.
Shall I stop sharing the screen then?
Yeah.
Yeah, okay. That's fine. Yeah. So the questions, video of a movement disorder can be asked. So that's the question. Yes. I mean, you can be shown an ECG. Let me tell you that you are MBBS doctors. You can be shown an ECG and ask you to read the basics of that ECG. An EEG can be shown on the screen and ask you to find out what is the abnormalities in that EEG. A CT scan can be shown with a head injury or subdural hematoma or a tumor, meningioma, or the common things, which can, or say even Alzheimer's disease, wherein there are, or vascular dementias, where there are lacunar infarcts. So those can be shown as well. And video of a movement disorder, definitely you may sometimes you may need to identify that movement disorder as well, and then talk about that movement disorder. How do you manage it? Yes. So these are the various scenarios that can be conceived in an OSCE. Please tell the scheme for suicide assessment. How to interview with references. Interview with references. I don't know what that means, but yes, I mean suicidal risk assessment. That's what we keep telling the people, right? And that the standard scale is there, suicidal intent scale by Bex. So you ask the questions in those scale, risk assessment, and then you get to the suicidal assessment. Right. And how to confront a patient with substance use if he denies substance use. I don't know, this may not be asked in the OSCE question, but yeah, generally out of the OSCE questions. The first thing is you need to ask about his lifestyle. Probably you need to ask about his day-to-day activities. You may have to ask about his relatives, friends, and all those people, and ask them if their friends have any substance abuse, right? And then sometimes you may say that substance abuse need not always be an addictive disorder or addiction disorder or disease that requires treatment. Use can be occasional, use can be regular, use can be what is called as sporadic. There can be binging, and then there can be addictive type of behavior. So, I mean, once you keep asking them all these questions without being confrontative, what we say as facilitative interviewing. So you are facilitating the patient to come out of or what is called as express his thoughts out. Yes, any other questions?
There is one more.
Any other? I don't see any questions. 1 minute, I'm just going down. Yeah. This is the first time an exam of this format is going to be held. As a teacher, can you elaborate how the faculty can help students? Right. So how the faculty can help students is faculty can help them prepare the questions, possible OSCE questions, and ask the students to what is called as answer them in an exam pattern in those 5 minutes. Practice, practice, practice. Right. That's all happens for the next 1 month. So I think your exam is on 11th of August. So for the next 1 month, as much as around 100, 200 OSCEs that you need to practice. How can major depressive disorder symptoms be elicited while there is very little chance of establishing rapport at a short time. Right. So it's not like the other patient on the other side is very rigid. I don't know if the clinical scenario is like this. I mean, you'll have a computer laptop and probably you may have to just type in those questions as to what are the symptoms of major depressive disorder. I don't know whether they'll be answering from the other side, but then rapport need not be established because there won't be any live patient. Probable OSCE in community psychiatry. Right. So in community psychiatry, there'll be what is called as you have received a telephone call from a primary health center or a patient who's living in a remote village, say for example, and then he's say expressing that he's having thoughts of suicide, right, or an acute psychotic disorder. So how do you manage that case when you are far away in the what is called as in the city or you're far away from managing that patient? So the typical that can be the scenario which can be given in a community psychiatry, or the patient is say living along with his brother in a house, and the brother has some urgent work and he leaves, tells the brother that he's going off to another city, and how can the patient what is called as get his medicines on a daily basis, or suppose he's decompensated, how do we manage that? So you send some social worker to the patient's house and see what all are the requirements and then help in fulfilling that. So that can be scenarios in community psychiatry. And how to assess craving for substance. What is the ideal question to put forth? Right. So usually when they ask for craving, is that does he what is called as hide the substance the last thing in the night so that he'll have it in the first thing in the morning? Right. So that is one question we can ask. And first thought that comes to you when the patient wakes up from bed. So does he think that, okay, I have to drink my alcohol drink at 11 o'clock, or does he think about the substance? So that is what is craving, the desire to take. And then does he what is called as divide his day when he should what is called as take alcohol, because that occupies his brain most of the time, that thought of taking alcohol or the substance in between the works. So that's what it means. So there are three questions that you can ask for craving. And can psychology question apart from testing be asked? So what is psychology question? This is the clinical examination. Yeah, CBT can be asked. If that comes in psychology, psychotherapeutic interventions, right? What are various psychotherapeutic interventions can clinical psychologists, whichever they can have, that may come up in the OSCE stations, questions related to that. Since when is this pattern of exam being implemented? Are the students to type out the answers? Right. I came to know about this pattern just 2 days back because Dr. Mahesh has asked me to what is called as take this session at a very short notice, and I can't say no to Mahesh anytime. Whatever he asks, I have to give it, and I have to give it. Even if he gives me a time of half an hour or 1 minute also, I have to give it to him. Right. So students to type out this answers. This is the first time it is being implemented for the DNB, and the first exam will be conducted on 11th of August. So that is the dates, DNB exams. And are the students to type out the answers? I think more likely, yes, they have to type out the answers. Yes, Vasundhara?
So we will be provided with answer sheets.
You'll be provided with answer sheets. Okay.
25 answer sheets, and we'll have to number them and write down the answer in 5 minutes.
Right. Okay. So you'll be probably provided with answer sheets, and those answer sheets are the what is called as submitted, and they'll be corrected. Actually. Yeah. Yes. Right. And will the candidate be given a patient or dummy actors? What is the time limit? No, it will always. I think the candidate will not be given any patient or dummy actors. I think they'll be on the computer screen. I think NIMHANS has been conducting this exam, part of their exam, in the form of OSCEs. So if anyone from, from NIMHANS, either the students or the PGs or the faculty, I mean, they can give, say, what is called as trial questions from their question bank, right? And then you can practice on those questions.
Dr. Naresh, NIMHANS actually has tried to do the OSCE format for the first time in the current academic year, and around 36 students have evaluated on OSCE format this time. The first class was actually taken by Dr. Pratima Murthy and Dr. Shamsundar from NIMHANS, and we are going to have a Friday session again from faculty from NIMHANS. So they're going to talk about their experience from what they've been trying to do and their format of exam. There's also one more question from the chat which talked about post-MD people, about their DNB exams, dates and things like that. Actually, currently we're not aware. Looks like DNB seems to be in a hurry on a priority of trying to finish the exams for primary candidates and post-diploma candidates. Probably they're going to take up this next, is what I just guess. Sometimes they may skip a term. It's happened in the past when they don't get centers, when they don't get examiners. They've actually skipped terms sometime. But looking at the current scenario, they may reschedule and give a different date, is what I think would probably happen.
Right.
Naresh, I think the last 1 hour has been highly productive, and you really explained the case scenarios very well. And I've actually looked at most points to be discussed for a scenario like that, in terms of the examiner's point of view, what the student needs to say, and to at least get to threshold of passing the exam and to get the minimum scores there. I would really thank you. With such short notice, you really came up with a presentation, and it must be a lot of brain teasing and refreshing memories of what you've done in the past. And I thank you for accepting this invite from Telearogya team and being there for us today. We also would like to announce that the next class is going to be on Wednesday 3 to 4, and the next one would be on Friday 3 to 4. We are planning to have a mock exam on Saturday. We are still trying to get the format and see how we could do it, and timings will be intimated shortly. I think the invite will go to all of you, and we're going to try and have as many classes possible. Monday, Wednesday, and Friday is what we think, and a lot of mock exams is what we're thinking, just to make sure the students are well prepared. And I've requested a lot of friends and faculties to be a part of it. A lot of people have volunteered. So I'll put up a timetable and it'll be intimated shortly on that. Thank you, Naresh, for anchoring this show and making sure the students were enlightened on OSCE's expectations. And from behalf of the Telearogya team, I would like to congratulate you for this wonderful presentation and a good show in the last one hour. Thank you so much. Vasundhara, I would request your help to coordinate to make sure that invite goes to everybody and we don't miss out anything. And I'll get the format of the other classes in short notice. Sriram has been of a lot of help for us. He's been the technical support from Icon, and he's really made sure the program really goes well, and he's made sure the invites were good and it's all passed on time. So I request Sriram to continue his good work and support in this series. Thank you, students.
Thank you, Mahesh and Vasundhara.
Thank you, delegates, and thank you, students, for your participation. I think it's all for you. Make sure you're present in the same numbers or even larger numbers to make sure this program goes to be a very good series for Telearogya. Thank you so much.
Thank you, sir.
We'll meet again on Wednesday. Thanks. Bye.